Welcome back. If you're here, you want to get past the jargon and really understand complex medical topics, especially for our pets.
And today, we're doing just that.
We're taking a deep dive into a specific type of bone tumor. We've sifted through the medical texts to bring you the core info.
We're tackling chondrosarcoma, or CSA as it's often called, affects both dogs and cats.
Right, CSA. Now, it's a bone tumor, malignant too, so it can spread. But the key thing, according to the source material,
Is that it produces cartilage-like stuff, this sort of matrix.
exactly, a chondroid matrix, they call it. But crucially, not actual bone. It's like a mimic, almost.
That's a good analogy. And it's important to know where it fits in. For dogs, it's actually the second most common primary bone tumor.
Primary meaning it started in the bone, yeah.
Precisely, not spread from elsewhere. It accounts for maybe 5 to 10% of those primary canine bone tumors.
Okay, so significant. And cats.
Less common in cats overall. When they get primary bone tumors, CSA is number 3, behind osteosarcoma and fibrosarcoma.
Got it. So our mission today is to pull out the essentials. Where does CSA usually show up? Which pets are more at risk? How do vets even identify it? And crucially, what are the options?
Let's jump in. Location seems like a good place to start.
Okay, location, location, location. And it's kind of surprising where it likes to settle.
It really is. There's a definite preference for flat bones, part of the axial skeleton. Think skull, spine, ribs.
Ribs, okay.
Well, a big one is the nasal cavity. Our source says around 30% of CSAs are found there.
30% in the nose. That seems unexpected for bone cancer.
It does, doesn't it? And that 30% actually makes up about 15% of all nasal tumors found in dogs.
Wow, so if you see nasal signs, it's something vets have to consider. What might an owner notice then? Discharge?
Yeah, things like ongoing nasal discharge, maybe some sneezing, trouble breathing through the nose, sometimes even facial swelling if it gets large.
Makes sense. And you mentioned ribs, too.
Yes,
Look
ribs are another key spot. About 20% of CSAs are found there. And here's the kicker. Those account for 30 to 40% of all primary rib tumors.
So if a dog has a primary tumor on a rib, CSA is high on the suspect list.
Very high, yes. Definitely something vets look out for in that location.
So we're talking nasal cavity, ribs. These aren't the legs, which I think many people associate first with bone cancer.
That's true. Osteosarcoma is more common in the limbs, the appendicular skeleton.
But CSA can show up in the limbs, too.
It can, yeah. About 20% of CSA cases are in the limbs, sometimes even in the same spots where osteosarcoma typically appears.
Oh, interesting.
But, and this is important, even though it happens, CSA only accounts for maybe 3 to 5% of all primary bone tumors in the limbs.
Okay, so much less common there compared to osteosarcoma, for instance.
Exactly. It's possible, but less likely than in those flat bones.
We've hit the main spots.
Yeah.
But the source mentioned some other less common locations, too.
It did. It's been reported in other facial bones, the skull proper, vertebrae, the pelvis.
Pelvis, okay.
Even the digits, and believe it or not, the os penis in male dogs.
The os penis. Wow,
Oh.
that's definitely specific.
And very rarely, it can pop up in soft tissues, away from bone entirely. That's called extraskeletal chondrosarcoma, rare in dogs.
And cats. Any specific location notes for them?
The main thing mentioned for cats, besides the typical bone locations, is the link to injection sites. It can be a type of injection site sarcoma.
Oh, that's a known issue in cats. So
Oh.
quite a range of possibilities for where this can turn up.
Definitely keeps veterinarians on their toes.
Okay, let's shift gears. Who gets this? What's the typical patient look like? The signalment, as they say.
Right. Signalment age, breed, size, sex. For dogs, the trend leans towards medium to large breeds,
Like weight-wise.
typically in the 20 to 40 kilogram range, so roughly 45 to 90 pounds.
Okay, and specific breeds mentioned.
The source lists a few as being overrepresented. Mixed breeds, actually.
Oh, really?
Yeah, mixed breeds, golden retrievers, boxers, and German shepherd dogs.
Interesting mix. Goldens, boxers, GSDs often pop up for various things. Does the source hint at why? Genetics, maybe?
It doesn't really speculate on the why, just notes the observation. But yeah, when you see breed predispositions, genetics is often a suspected factor, though more research is usually needed.
Makes sense. What about age?
The median age is around 8 years old.
Middle-aged to older, then.
Pretty much. But the range is quite wide. They've seen it in dogs as young as 1 year and as old as 15.
Okay, so primarily medium-large, middle-aged dogs, certain breeds may be more susceptible. What about cats?
Well, that's where it differs quite a bit. The text says cats are rarely affected overall.
Really? Much rarer than in dogs.
Seems so. And unlike dogs, there are no obvious breed or age links mentioned for cats in the material we looked at.
That's quite a contrast. Any idea why? Just less common overall or harder to spot?
The source doesn't really theorize. Could be biological differences, maybe detection challenges, or just lower incidences. It just highlights that difference between dogs and cats for CSA.
Good to know. Okay, so we know where it might be and who might get it. How does it actually show itself? What signs might an owner notice first?
Often, the first thing is simply noticing a mass or swelling at the site. Just a visible lump.
Okay, a lump. What else?
If it's in a limb, especially a weight-bearing bone, then lameness is really common, limping.
Makes sense. Pain in the leg. What about those rib tumors?
With rib tumors, sometimes you might see breathing changes, maybe some respiratory signs, or just that visible anomaly on the chest wall. But often, signs can be subtle initially.
It really depends on the location.
Absolutely. The
Yeah.
signs are very much tied to where the tumor is growing and what structures it's affecting.
And what would a vet find on a physical exam?
Typically, they'd feel a mass, usually described as firm and maybe even hard.
Painful.
Often, but not always. Some are painful on palpation, some aren't, apparently.
Interesting. Anything specific about the rib ones on exam?
Yeah, the source notes they commonly arise at the costochondral junction.
That's where the rib bone meets the cartilage part, right?
Exactly. And maybe because that junction has a bit of give, the tumors can sometimes grow quite large before they really cause obvious breathing issues or dyspnea.
So dyspnea is rare with rib CSA.
It seems rare, yeah. Usually only happens if the mass gets really big and physically takes up space in the chest cavity. Any rib can be affected, though.
Okay, so firm mass, variable pain, location-dependent signs. Now, the big question, why? What causes this? Any known risk factors?
Well, like with many cancers, the short answer for the primary cause, the etiology, is we don't really know.
Largely unknown.
Okay.
Frustrating, but honest.
It is. But there is one significant risk factor the source highlights.
Ooh, what's that?
It's the transformation of lesions from a condition called osteochondromatosis.
Osteochondromatosis, what is that exactly?
It's a condition sometimes called multiple cartilaginous exostoses, where an animal develops multiple benign bony growths capped with cartilage.
Okay, so extra bumps of bone and cartilage.
Right. And apparently these benign lesions have the potential to undergo malignant transformation into chondrosarcoma.
Ah, so that's a crucial link. If a pet has that condition, they're at higher risk for CSA.
That seems to be the connection, yes.
Yeah.
It's a known pathway for some cases.
Is that condition common? Should owners whose pets have it be particularly worried?
It's not super common, but it's recognized. And yes, if a pet has diagnosed osteochondromatosis, vigilance and monitoring for changes would definitely be recommended.
Okay, so mostly unknown cause, but this one clear risk factor. Now, diagnosis. If a vet suspects CSA, how do they figure it out for sure? Sounds like lots of things could look similar.
You're right. The differential diagnosis list is pretty long. It's a process of elimination.
What kind of things are on that list?
Well, first, other primary bone tumors, osteosarcoma, fibrosarcoma, hemangiosarcoma.
The other main bone cancers.
Exactly. Then you have metastatic tumors cancer that started somewhere else and spread to the bone.
Like from where?
The source gives examples like certain bladder cancers, transitional cell, prostate, mammary, thyroid, even anal sac carcinomas can spread to bone.
Wow, okay. Lots of possibilities there.
And there's more. Locally invasive tumors like an oral tumor growing into the jawbone or a nasal tumor into facial bones. Plus, non-cancerous things like bone infections.
Infections.
Like bacterial.
Bacterial or fungal osteomyelitis, yeah. Those can cause bone destruction that might look like cancer on an X-ray initially.
So ruling things out is key. How do they start? Basic blood tests.
That's usually done, but the source points out that standard blood work, CBC, chemistry, and urinalysis are often completely normal with CSA.
So normal blood work doesn't rule it out.
Not at all. It's more useful for checking overall health and maybe ruling out some other systemic problems, but not usually diagnostic for CSA itself.
Okay, so blood tests aren't the main event. Imaging must be crucial then. X-rays.
Absolutely essential. Radiographs of the suspected area are usually the first step.
What do they look for?
They look for signs of an aggressive bone lesion. Things like bone lysis areas where bone is being destroyed,
Okay.
cortical destruction damage to the hard outer layer of the bone, maybe some patchy, disorganized new bone formation, and usually an ill-defined border. The tumor edge looks fuzzy, blending into normal bone.
That fuzzy edge sounds like a key sign of trouble. It often is, yeah. Suggests it's infiltrating. And importantly, Chest x-rays, thoracic radiographs are always recommended too.
To check for spread.
Exactly. To look for lung metastasis, which is the most common site for CSA to spread to.
Okay, X-rays give the initial picture. What about more advanced imaging? CT scans.
Yes, CT scans are particularly important for those axial tumors. Nasal, ribs, spine, skull.
Why CT for those specifically?
Because CT gives much better detail of the bone and cross-section. It helps see the true extent of the tumor, which is critical for planning treatment.
Like planning surgery or radiation.
Precisely. You need to know exactly where the tumor boundaries are. And if you're doing a CT of the primary site, they usually recommend doing a CT of the chest at the same time.
Better than X-rays for finding lung mets.
Generally considered more sensitive, yes.
Yeah.
Can pick up smaller metastatic nodules.
So imaging tells you a lot about location, size, spread. But how do you get the final definitive answer? What type of tumor is it?
For that, you really need tissue. Histopathology is the gold standard.
Meaning a biopsy.
Yes. Taking a sample of the tumor tissue itself and having a pathologist examine it under the microscope, that's how you confirm it's chondrosarcoma and not something else.
Can they use just a needle aspirate, like sticking a needle in?
A fine needle aspirate collecting cells with a needle can sometimes provide supportive evidence, maybe suggest cartilage cells are present, but the source emphasizes that a larger tissue biopsy for histopathology is needed for the definitive diagnosis.
Got it. Biopsy is key. Okay, so let's say the diagnosis is confirmed, chondrosarcoma. What happens next? What are the treatment approaches?
It really depends on the location again.
Right, so for limbs versus axial skeleton.
Exactly. For appendicular tumors, those in the limbs, the standard recommendation is usually amputation.
Removing the whole limb.
Typically, yes. That provides the best chance of removing the entire tumor.
Okay. And for the axial ones, ribs, nasal cavity, etc.
For axial tumors, the goal is wide surgical excision whenever possible.
Meaning taking the tumor out with a generous margin of healthy tissue around it.
That's the aim. But it can be really challenging in some spots.
Like the nasal cavity or spine.
Exactly. Getting wide margins there without damaging vital structures is difficult, sometimes impossible.
So surgery is the main approach, if feasible. What else is in the toolkit? Radiation.
Radiation therapy is definitely an option, particularly if surgery isn't possible or if they couldn't get clean margins.
Any specific type?
The source mentions stereotactic radiation therapy, or SRT.
SRT, that's the really focused kind, right? High dose, very precise.
Correct. It's used effectively for local control in canine osteosarcoma, and the text suggests it could be a good alternative or addition to surgery for CSA too, especially for those difficult-to-operate locations.
Okay, so surgery, possibly radiation. What if those aren't options? Say the tumor is too advanced or has already spread, or the owner opts against aggressive treatment.
In those situations, the focus shifts to palliative care.
Keeping the pet comfortable.
Absolutely. Primarily focused on pain control and maintaining the best possible quality of life for as long as possible.
Pain management sounds critical for any bone tumor. What medications do they typically use?
There's a range. Non-steroidal anti-inflammatory drugs, NSAIDs, are common.
Like meloxicam or carprofen?
Those kinds of drugs, yes. Also, other pain relievers like tramadol or gabapentin are often added.
Layering the pain relief.
Exactly. And for bone-specific pain, they might use intravenous drugs called aminobisphosphinates.
Like pemidronate.
Pemigonate or zoledronate are examples. They can help reduce bone pain and also slow down the bone destruction caused by the tumor.
Okay, that makes sense for bone pain. What about chemotherapy? Is that used for CSA like it is for, say, lymphoma or osteosarcoma?
That's a really interesting point in the source material. It states pretty clearly that the role of chemotherapy for veterinary CSA is basically undefined.
Undefined, meaning we don't know if it helps.
Pretty much. And importantly, it points out that chemo doesn't seem to improve outcomes in humans with chondrosarcoma either.
Huh. So unlike many other cancers, chemo isn't a standard part of the plan for CSA.
It appears not, based on this text. The biology of chondrosarcoma might make it less responsive to chemo drugs, perhaps because it's cartilage-based or grows slower. The source doesn't detail the why, just the what.
That's a crucial piece of information for owners managing expectations. So focus is on local control, surgery radiation, and pain management.
That seems to be the mainstay.
When using those pain meds, especially NSAIDs, any precautions?
Yes, definitely. The source includes important warnings. NSAIDs need to be used cautiously in all cats and also in dogs with any kidney issues.
Okay, caution in cats and kidney patients.
And a big one. Never combine NSAIDs with corticosteroids like prednisone.
Why not?
The risk of serious gastrointestinal side effects like ulcers and bleeding goes way up. It's a major contraindication.
Good to know. Always follow vet instructions carefully with these meds. Okay, so after treatment or during palliative care, what's the follow-up like? And what's the outlet, the prognosis?
Monitoring is key. Regular checkups are recommended. Physical exams maybe every 2-3 months.
Feeling for recurrence.
Exactly, checking the primary site if possible, and overall well-being. And then imaging, usually chest x-rays every 3-4 months.
Still watching for lung mets.
Right, keeping an eye out for local recurrence or distant spread.
And what's the general course? Does it tend to spread often?
The overall metastasis rate mentioned is somewhere between 15 and 30%.
Okay, so not guaranteed to spread, but a definite risk.
Yes. And the lungs are the most common place it goes if it does spread. The risk is higher, maybe closer to 50%, for tumors that are graded as high grade on the biopsy.
High grade meaning more aggressive-looking cells.
Correct. Higher grade often correlates with higher metastatic potential.
So what's the survival look like if they have, say, aggressive surgery for a limb tumor?
With aggressive surgery like amputation for a limb CSA or complete excision for an axial one, the prognosis can actually be quite good for local control. The median survival time is reported as being greater than 3 years.
Wow, over 3 years median. That's pretty good for a malignant bone tumor.
It is significantly better than typical osteosarcoma, for instance. Many dogs can achieve long-term local control.
But you mentioned local recurrence earlier.
Yes, that's the catch. Even with surgery, local recurrence can happen. The source suggests rates up to 40%, depending on the location and how complete the surgical removal was.
So getting those clean margins is really critical.
Absolutely critical for long-term success.
What about if they only do palliative care? No surgery or radiation?
Even with just palliative care focusing on comfort and pain management, survival times of over a year are still considered possible for some animals.
Okay, so even without aggressive treatment, some pets can still have a decent amount of quality time.
Yes, the progression can sometimes be slower than other bone cancers, allowing for extended quality life, even in a palliative setting.
That's a really helpful overview of the outlook. It's serious, but maybe not always as rapidly aggressive as some other cancers.
It seems to have a bit more variability, and aggressive local therapy can make a big difference.
Okay, let's try and wrap this up. We've covered a lot of ground on chondrosarcoma.
We have.
So key takeaways. It's a malignant bone tumor. Second most common in dogs, third in cats. Makes cartilage, not bone.
Likes flat bones, nasal cavity, ribs, but can hit limbs too, though less often than osteo.
Affects mostly medium to large, middle-aged dogs. Some breeds more noted. Cats rarely affected.
Diagnosis needs imaging x-rays, often CT, but the final word comes from a biopsy, histopathology.
Treatment hinges on location. Limbs often mean amputation. Axial tumors need wide surgical excision if possible, maybe with radiation like SRT.
Pain management is vital, NSAIDs, other meds, bisphosphonates, but chemo. Not really a standard treatment here.
Prognosis can be good with complete removal, potentially years, but local recurrence is a risk. Palliative care can still offer significant time.
That covers the main points from the source nicely. It really underscores how complex these cases can be.
Absolutely. Diagnosis, treatment planning, it really requires that veterinary expertise to navigate it all properly for each individual animal.
No doubt about it.
And thinking about this, especially the parts we don't fully understand, like the exact causes or why chemo isn't effective, it makes you wonder, what's next? What breakthroughs in understanding tumor biology or new targeted therapies might change the game for diseases like CSA down the road? Something to keep an eye on in veterinary oncology research.
A hopeful thought to end on.
Thanks for joining us for this deep dive.